Hello and welcome to the EMJ podcast with me, your host, Dr. Jonathan Sackier. Today I'm joined by Dr. Jane Van Dis, Assistant Professor of Obstetrics and Gynecology at the University of Rochester in upstate New York. Jane is a practicing OB-GYN, which is how such specialists are styled in America. I lived there for many years, and the first time I heard it, I thought, my goodness, that's so much more ear-catching than the British way of saying it. It sort of sounds heroic, like Star Wars Obi-Wan Kenobi. That's what my brain always deferred to. So, as I say, Jane is an assistant professor and advisor to groundbreaking health tech startups. She's been a bit of a trailblazer in women's health, equity, and innovation. She's the co-founder of several impactful initiatives, including Equity, Quotient, and OB Best Practice, and serves as a medical director and advisor to some companies, and we're going to discuss that. She's also a prolific writer. She's a sought-after speaker, and Jane combines her expertise in obstetrics with a passion for digital health, workplace equity, and mentorship. Beyond her professional achievement, she's a mum to twins and a tireless advocate for empowering women in science and medicine. So it's my pleasure to welcome to the podcast Dr. Jane Van Dis. It's an honor to have you here.
Thank you, Jonathan. Thanks for the invitation.
Most welcome. So, Jane, since you entered the field, how has obstetrics evolved over the years, and what brings you the most satisfaction?
When I entered the field, I think that there was a dearth of the types of rigorous scientific studies that there had been in other specialties. For instance, of course, internal medicine and surgery, and even pediatrics, because there is this reticence, obviously, to conduct the same types of studies on pregnant women, for instance, than in the general population. And so I feel like as a specialty for a long time, we practiced more anecdotal medicine than other specialties. So I do think that there has been increased scientific rigor applied to our specialty. Having said that, it's been interesting, Jonathan, because I do feel while at the same time we have seen more and more robust studies, we've also seen a public that wishes to go back in some ways to a practice of obstetrics that was relevant in the 1800s or the early 1900s. So there's this push from, I would say, a more natural perspective. Now, when I say natural, of course, that's something, it's a word that finds itself in any given decade as representing something different, right? And, what was natural in 1910 was not the rates of hypertension, diabetes, and obesity that we see now. So in some ways, I do feel like there's this, science fiction imagination as to what women's bodies should be capable of doing or are capable of doing, and it skips 100 years. I totally apprehend that women want natural births. For instance, they don't want to have a cesarean section. But there's an antipathy towards those of us who provide those cesarean births. And, we are not responsible for the many health indices that have changed over the last 100 years. We see this in the US. I'm not sure how prevalent it is in the UK, but we see this as well in a rejection of public health and vaccines now. So there's this very like fascinating but also horrifying tug between an increased edification and an increased precision in the way that we think about obstetrics and gynecology, and yet a very significant pushback against medical science. Now, I will say, having spent a lot of time understanding the role that inequity has played in the development of our specialty, I do understand and I am sympathetic to the ways in which misogyny and systemic racism have played a role in some of the way that obstetrics and gynecology has been practiced. So I don't want to diminish that at all. Having said that, there are ways to address that bias and still adhere to scientific principles. So anyway, there's tension there. There's definitely tension there, Jonathan.
Yeah, well, we're going to come on to one of those things that you mentioned, racial disparities. I lived half of my life in the United States, and a very dear friend of mine, Dov Barron, who is a very brilliant man. I encourage everyone listening to check him out, Dov Barron, dovbarron.com. Brilliant guy. He talks about emotional source code, and he did this little test with me and said, what would be the emotional source code, the hardwired nature of a British person compared to an American? Because there are differences. Of course, today you can't even mention it because it's politically incorrect to have these discussions, when of course it's madness, because men and women, we were taught at medical school even back then that women are not more curvaceous versions of men.
Yeah,
You're a different organism. Children aren't small adults.
that's right.
And he talks about the American emotional source code, which is, what words do you associate with American? You think about freedom. Americans are convinced that they're freer than any other nation on the planet. I don't agree with it because
I don't either.
yeah, I mean, we're pretty free over here, and the health system doesn't dictate to us. But I think if you tell Americans get vaccinated, their natural reaction is going to be, you're not telling me what to do.
That's right.
So maybe bringing people on a journey is a much better way of engaging with people. And I know that, nowadays that's much more of a thing for your specialty and mine. So let's get on to let's dig down into some of your specific interests. I know you're very interested in patient safety checklists, protocols for labor and delivery. I'm a pilot, I've been flying for years.
Oh yeah.
I've always been a huge advocate
Yeah.
of using such approaches, no matter how experienced one is. I flew the same aeroplane for many, many years, yet every time I got in it, I used the printed checklist. Why?
Right.
Because
Right.
it just takes one distraction and you'll
That's
miss something key. So
Right.
can you talk to us about the evolution of that thinking in your specialty and give some examples of where deployment leads to safer and better outcomes?
Yeah, I definitely adhere to the pre-checklist. I was married to an airline pilot as well for 10 years, so I'm very familiar with the two industries and how they have used each other's tools to the betterment for
Mhm.
safety. Um, I will say I don't think, unlike surgeons who oftentimes are thinking about laterality, that is to say, removing the right kidney versus the left kidney. I do think that it doesn't appear in my specialty so often that there is a near miss with a checklist, for instance. I do find it helpful, especially in cesarean sections, when, for instance, a patient wants their tubes out. And we do recommend bilateral salpingectomy for sterilization now in the US in order to prevent that primary peritoneal cancer that, is associated with ovarian cancer. And so occasionally there have been patients who, when you ask them to ensure that that is what they want, that they do change their mind. Unfortunately, in the US, we have a very paternalistic approach to sterilization such that you can't change your mind the other way, which is to say, maybe you weren't anticipating having a cesarean, but you want to have your tubes taken out. If you are on federal healthcare insurance, you're not allowed to make that decision. If you have private insurance and you decide at the last minute that you want to have your tubes taken out, you can have that procedure during a cesarean section where your body is already open.
Huh. That's absolutely. I do that it strikes me so often that I go to bed less dumb, but I learn stuff every day. I lived there for many, many years. I did not know that, and that's astonishing. It really is. So let's dig in again to another difference between the systems. Every healthcare system has its challenges, providing to its population. As I said, I was trained over here, worked in the United States. Anytime one talks about race or gender related outcomes, there's a danger of what are effectively scientifically critical conversations, but people get very sensitive and they descend into political diatribes. For
Yeah.
instance, I read a report recently and then heard Bill Maher, who's an American
Yeah,
a
I know who
comment.
he is. Yeah.
I love Bill Maher. He cracks me up. Brilliant guy. And he was talking about it, and it was about gender. It was about African American women had a significantly higher rate of C-sections. True, and it was interesting. It was true both for Black Medicaid recipients, so people at the lower end of the socioeconomic scale, and higher income nulliparous women. And outcomes are worse. Two-part question. How do we have these discussions free of concern and erode people's political, oh, you can't talk, oh, we can't talk about that? And then please address this specific example.
Yeah, so I do think that obviously, Jonathan, we have to have the tough conversations. There's no room for saying that, oh, well, that makes me uncomfortable, or oh, that might be too politically incautious or something like that. We are scientists. We were trained to discuss our field. Obviously, we shouldn't be dabbling in other people's areas of expertise, but this is our area of expertise. Having said that, one of the things that I've been looking at in the last few years is the environmental exposures that people of different races in the US experience, and what are the healthcare outcomes of those. So, for instance, we see with meta-analyses, a meta-analysis of over I can't remember how many studies, hundreds of studies showing that when you have women who are pregnant who are exposed to air pollution, you have increased rates of preterm birth and low birth weight babies. But those results are more profound among Black mothers. So, Black mothers more likely to deliver preterm due to exposure to air pollution. Now, that's just one exposure. We can talk about PFAS, we can talk about phthalates, we can talk about PDBEs or fire retardants. And in almost every situation, Black women are exposed to higher rates of environmental toxicants. Now, some of this studies have shown comes through with some of the hair and personal care products, again, which is either a straightener or a relaxer, and the chemicals in these products are having deleterious effects on human health. But the more you use the products, the more exposure that you have. Now, I do not want to say or imply that environmental exposures explain all of the discrepancies in birth outcomes between Black and white Americans, but they definitely explain a lot, because in the history of the formation of American cities, for instance, we saw redlining. We saw the way in which neighborhoods were, exclusive of Black people sometimes, and the way in which polluting industries were located next to Black neighborhoods. So the degree of environmental racism in the US, and I don't know if this holds true in the UK, but the degree of environmental racism in the US is profound, deleterious, and actually takes significant numbers of years off of their lives due to these exposures. So I've created a TikTok channel where I talk about environmental exposures and pregnancy. I'm really sad that TikTok might be going away. I have 22,000 followers. I just started this channel in September, and I get a lot of positive feedback about people learning about some of the ways in which our environmental regulations are not protecting us. And let's be clear, when we are pregnant, that is the most vulnerable time in a human's life. Their blood-brain barrier has not yet perfectly formed. Their ability to remove toxicants, the fetus's ability to remove toxicants from their body, the filters, as it were, are not fully developed. Their cells are dividing at a rapid rate, so therefore they're at increased risk to chemicals that will harm them. So there is just not enough discussion about the ways in which these environmental exposures are affecting our pregnancies and are leading to some of the racial differences that we see in outcomes.
Wasn't aware of that. The UK, well, listen, we have challenges over here, and maybe this will be a topic for a future conversation between us. But it's not as the neighborhoods. I think I always thought going to America, it's billed as the melting pot. I always saw it more of a minestrone than a melting pot, frankly. And there are these areas where you have exclusively an African American community or a Hispanic community. There are some pockets in the UK, but it tends to be a little bit more diverse. I live in an area of London where um, I think there's probably 120 nationalities within a mile of where I live. So, yeah, there are different challenges, of course. So, I want to move to your advocacy work. You're the co founder of Time's Up Healthcare and CEO of Equity Quotient. You've been a leader in addressing gender equity in medicine. Can you share some key insights or progress you've witnessed as a direct and proximate result of these initiatives?
Yeah, so at Equity Quotient, we tried to create a tool that would measure equity in healthcare. And what we found, unfortunately, Jonathan, is that when we presented the C suite, the CEO, the COO, the CFO, the CMO, when we presented them with data about how they could change their organization to be more equitable, what we found was that they weren't interested, frankly. And the fact of the matter is that if you want to have an equitable organization, you not only have to appoint people of color and women and LGBTQ people to administrative or leadership roles. You have to address all of the microaggressions, of course, that occur in the work environment. And now what we're seeing, Jonathan, I'm not sure if you're aware, but there is a huge backlash in the US against
Yeah.
all of these DEI initiatives. So to the same thing that we experienced when we went, the C-suite paid us to do this analysis of their organization, and they were anathema to understand and apprehend the results and what they would need to do in order to make their organization more equitable. The fact of the matter is that people in power are not interested in sharing power. And people in power are not interested in addressing their own racism or their own misogyny. And until and unless those who have power are willing to do that, we will continue to see any type of backlash against grassroots efforts to even just name the problem. That's where we're at.
Hmm. Interesting. Yeah, I've been reading about it. I normally try to steer away from politics, which is a pity because they can be the most interesting conversations. But yeah, I mean, listen, it's making front page news. So you've been switching tack a little bit. You've been involved in numerous health tech startups.
Yeah.
It's an area that I love and have done a fair bit of. What excites you most about the intersection of digital health and women's health? And how do you see this field evolving in the next decade? I'm sure you're going to use the letters AI at some point. But
Well, I am and I'm not. The thing that excites me most was the idea of having increased remote patient monitoring, right? So the idea that we know that biofeedback plays an integral role in people's ability to control their health outcomes. So, for instance, the ability to have one of those devices that measures your blood glucose in real time, and then have that meter attached to your phone so that you can get an alert as to a high blood sugar or a low blood sugar. That's like immediate biofeedback based on a remote patient monitoring that can drastically improve health outcomes. We see the same opportunities when it comes to blood pressure control, where you can attach a device to your phone and tell you, if, for instance, you're at 34 weeks and your blood pressure is 200 over 100, you need to go to the hospital right away. So that's what I was hopeful about. But to be honest, Jonathan, I am not hopeful at all about AI. In fact, I am anti AI. And the reason is because what we're seeing across the country is that AI is using up so much carbon. And we are today at 425 parts per million of CO2 on or in Earth's atmosphere. We have put up since 1800 over 2.5 trillion tons of CO2. Now you can't see that CO2, but if we could see how much weight that gas is weighing on the Earth's atmosphere and obviously trapping our greenhouse gases and heating up our planet. There is an exact correlation between our eating animals, our flying, our use of AI, and the fires that happened in Los Angeles a week ago. So, no, I am not pro AI because I don't think we need another thing that we need to burn carbon for. That's
Okay.
what I have to say.
Okay. Well, thank you for that. I guess we're going to see how that all pans out.
It's
But
not panning out well, Jonathan.
well, I would wonder. We've seen with telemedicine, which certainly burns carbon, that it also reduced the number of people making car trips to come to the hospital for their appointments. So maybe there are,
No, absolutely. Telemedicine is a fantastic way to decrease emissions. I'm very pro telemedicine.
yeah, I think something can achieve the goal without having a negative. We just have to apply our minds as to how to best deploy it. So, if we can use AI, for instance, to create virtual avatars of controls to expedite clinical trials so we can get cures to patients the faster and maybe reduce the number of, visits that people have to make as part of a clinical trial. I'm just suggesting that it's not one thing or the other. There may be rational ways that we can deploy something without having the negative effects. But maybe I'm just an idealist. I don't know. But uh, in a similar vein, you've been an advisor to a number of startups. What trends are you seeing in FemTech? Certainly, I'm seeing a lot more investment. And as I seek to raise money for various startups, people are saying, well, is this FemTech? If it's FemTech, I'm really interested. So I'm certainly seeing that there's more money being deployed against it. But what trends are you seeing, and what advice would you give to an entrepreneur looking to make a meaningful impact in women's health?
Well, I actually haven't seen an increase in monies here in the US. In fact, we've seen a rollback and we've seen many startups go under. So I do think it's actually a precarious time to be a startup in femtech. The companies that I have worked with that have been successful are successful because they can prove outcomes. I do feel like in the late 20 teens, we saw a lot of entrepreneurs come forward with a solution whose ROI was sketchy and whose ability to measure outcomes was also precarious. I think those that will be successful will be so because they can prove their worth, both financially and with moving the meter on patient outcomes. I do think there are a lot of apps out there that are more, a great idea in a perfect world that had unlimited resources, but we don't live in that world. And so I do think that devices are a great sector. I do think that solving heretofore difficult problems like I've advised Flex over the years. It turns out that a menstrual disc or cup is better for the environment. Flex has shown, for instance, that they don't have any PFAS in their product, whereas tampons do. There's just a lot of ways in which the invention of something meets the mark on multiple different levels. And Flex would be a product like that. I can think of a lot of startups that we actually don't need, though.
So can you tell us, for that, I looked into Flex and I read about Lauren Wang and her story. Do you want to share some of that with our audience? It's fascinating.
Oh, sure. Yeah. So I met Lauren before they were even manufacturing products. She had just graduated from Y Combinator and she had a brilliant idea. Now, she did not invent the menstrual disc. That company already existed, EvoFem, and they purchased the company. And obviously, the company was not one that a lot of American consumers had heard about it. They had a product called Soft Disc. So they bought that company, but then they rebranded it and they used social media to tell a story about why it wouldn't be a product for everyone, but it might be a product if, for instance, you suffered from recurrent yeast infections, or if you suffered from recurrent different types of bacterial vaginitis. For instance, if you wanted to have sex while you were on your period. There are plenty of reasons to think about using a disc, a menstrual disc. It sits at the top of the vagina. The majority, 99.9% of women can't even tell that it's there. And it has 3 to 4 times the absorbency of a super tampon. And then they hired a woman who actually has Ehlers-Danlos syndrome, and she was having difficulty removing menstrual cups. So menstrual cups obviously sit just past the vaginal fornix, and you have to reach up and grab the stem and pull them down. And so she created a cup that has a pull tab at the bottom. So when you pull on the bottom of the cup, it releases the air at the top of the cup, thus releasing the type of suction that some women can have at the top of the cup around the vaginal walls and potentially the top of the cervix. So this, I thought, was a brilliant invention. And many women have appreciated the ease with which they can place and remove this cup. So you're seeing, just innovation abounding. And then, Lauren, let's be honest, her social media channels, she started out on Instagram and Facebook, and now she's in all of the retail channels. She's in Target, Walgreens, CVS, the grocery stores. So really, really just amazing, constant, on the ground, resourceful action on the part of a founder. And I've been with her obviously through her ups and downs. She's had many since 2016. She's going on her 9th year now. But she's one of those founders whose grit and resiliency and intellect really knows no bounds.
Yeah. I'd encourage people listening to check it out. She's got a great personality as well, and she tells a very compelling story. So yeah, it's a great story. So you're also, I know, an advocate for sustainability in healthcare, specifically through your work as co-founder of OB-GYNs for Sustainable Future Within Healthcare Without Harm. Can you touch on, you've hinted at like carbon in the environment, carbon dioxide. What about the myriad of impacts plastics have on the body, and the initiatives your group has instituted to address this?
Yeah, so we are an interest group of Healthcare Without Harm. They don't want us to say that we're a formal body of them because they probably are worried that we might say something they would object to. But what we've done is we've interviewed key thought leaders in the area of both decarbonization of healthcare as well as the exposure to plastics and endocrine disrupting chemicals that are in all of our plastics. So some people might not know, but there are over 16,000 chemicals in the plastics that surround us. And if you've been to the grocery store, you might see that your bell pepper or your cucumber or your potato even potentially comes wrapped in plastic. Well, that plastic is not inert. It actually, those chemicals do make their way into the food that we're eating, especially if the plastics are heated, surrounded by anything that's acidic or those things that have high fat contents. The problem is that these chemicals are directly related to some key health outcomes. So for instance, there have been many meta-analyses focusing on phthalates and gestational hypertensive or hypertensive disorders of pregnancy. And there is a relationship between the exposure levels because you can measure the metabolites of that plastic chemical in the pregnant woman's urine. In addition, Dr. Trissan down at NYU, he showed that testing over 5,000 pregnant women's urine, he was able to make a postulation that potentially 1 in 10 preterm births in the US was due to elevated phthalate exposures of those women. So the exposures are worst, for instance, when we heat our food in plastic. So if you have Tupperware, I would say just get rid of it. Put your food in glass if you can. Absolutely never, ever, ever heat your food in plastic. This includes the containers that come in frozen food. You need to take your frozen food out of the container and heat that frozen food in glass. As I said, I have a TikTok channel. I've done 200 videos on this topic. I'm not sure what will happen if TikTok goes away this week. It's very sad. It's a great source of education. But I hope to be on, maybe YouTube. I heard today there's a Chinese app called Red Note where people are migrating to. But the bottom line is that these plastics are not inert. They are harming us. And there's more than 2 times the amount of biomass of plastic than there are of living things on Earth. So obviously 6% of all global oil goes into plastic. So this is absolutely a business decision by the fossil fuel companies to push more plastic out into the environment as we do decarbonize. And you mentioned decarbonization. The gynecologists actually in one study I looked at were the most had the highest level of emissions in their gynecological surgical suite of all the other surgical specialties. A great life cycle analysis was done showing, for instance, that a robotic hysterectomy produced significantly more emissions than, say, a vaginal hysterectomy did. It went vaginal being the lowest, then abdominal, then laparoscopic, and then robotic. So the ways in which we practice our specialty and the amount of single-use plastic that we consume in our operating rooms, the less reusable items we use, the worse the outcomes for the communities in which we live, because all of that plastic either goes into a landfill, which then leaches into the soil, or it gets incinerated and the plastic goes up into the air. So there's no escaping. And the things that we're doing are actually causing harm, hence healthcare without harm.
That was fascinating. I'm sure I heard this somewhere else, but I'm reminded of that. I think it was 1967, The Graduate with Dustin
Of course,
Hoffman
yeah.
and Anne Bancroft.
Yeah.
And there's a scene where he's just graduated college and one of his father's or mother's friends says, plastics, one word, plastics, the future, my boy, the future. Yeah, maybe the end of it's a very, very concerning problem. Seeing a lot about it. So tell us about what do you want to see to improve the future of women's health and equity in medicine, and what would you say to a young woman who's looking to go to medical school or looking to join your specialty?
Well, I would say fight for it. I would say, we are seeing that there are decreasing numbers of people of color who are able to matriculate into medical school because of the reversal of affirmative action and other programs in the US. And so, we absolutely cannot change the specialty by just adding more white people to it. I think, the data is pretty clear that Black women and people of color have better outcomes when they're cared for with people of concordant race. I'm not saying that, that I don't provide good care, but I am saying that those with privilege who have grown up with privilege absolutely sometimes do not see and do not communicate in a way that there is concordance with recommendations or an understanding of the types of food and environmental and living situations that people have, and therefore, social determinants of health are a huge contributor to adverse health outcomes in the U.S. And so, until and unless you can absolutely and efficiently analyze that, I think we're at a disadvantage to moving the metrics on some of those. So I would encourage women and people of color to continue to apply, but I will say that I think that it will be very hard to make progress, especially when we've rolled back some of these programs.
Look, it's very important to have these discussions. I talked to an American colleague recently about representation of, should we say, different groups. And I pointed out in Britain, because I recently gave a seminar on trauma, and there were 26 consultants attendings in the room. One of them and me were the only white men in the room. All the others were people of color. Mm-hmm. And in fact, I hope I get this right, the right way around, 51% of doctors in the UK are non-white, of junior doctors are non-white, and 42% of consultants attending are non-white. So actually way overrepresented in medicine compared to the general population. But
it's different than the US, yeah.
I'm afraid that's all we've got time for today. I'd like to thank Dr. Jane Van Dis for being with us today, and for all the work that you're doing, and for being a woman of conviction. Real pleasure to chat with you.
Thank you, Jonathan.
So, folks, if you've enjoyed this episode, please subscribe on Apple or Spotify, wherever you get your podcasts, so that you never miss an episode. Check out the archives, tell your friends, so on and so forth. You know the drill. And until next time, please stay happy, stay healthy, stay safe, stay well, stay curious. This is Dr. Jonathan Sackier for the EMJ podcast. All the best. Bye for now.